Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hey everybody, Dr. Mark Sims here. I'm the host of the Listen Up podcast, where I feature top leaders in healthcare. This episode is brought to you by Listen Up Hearing Centers. I help patients to effectively treat their hearing loss so that they can remain well connected with families and friends and remain independent. The reason I'm so passionate about hearing loss is because I lost my brother Robbie twice. First to his hearing loss from radiation to a brain tumor, and then later when he passed away. I only care for ears. I'm the E of ENT. I performed over 10,000 surgeries on the ear and have taken care of many more people with hearing loss. I'm the founder of Listen Up Hearing Center. I'm also the author of a book of the same name, Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. If you want to learn more about either of them, go to www.listenuphearing.com to learn more. Today, I have a great guest. It's Dr. Virginia Ramachandran. She's the head of audiology for Oticon. She's also a faculty member at Wayne State University, where she teaches courses in amplification. Her clinical and research interests have been diverse, but she has particular interest in students and professional issues, which is great for her role at Oticon. She has conducted numerous state, national, and international presentations and authored many articles, books, and book chapters. She's also served as an ad hoc editor for several academic journals and serves on the editorial board of Plural Publishing. She has an interesting academic background. She has received her BSW, MSW, AD, and PhD, all from Wayne State University. And she's the president-elect for the American Academy of Audiology. So there's a lot of great stuff for us to talk about. Dr. Ramachandran, Virginia, I hope, Mark, that'll work great. Welcome to the podcast. Thanks for coming on.
Thanks for having me. I appreciate it.
So tell me a little about, in your background, I was reading that, you started out in social work and then ended up in audiology. I don't think that's I understand the path, but it is unique. So can you tell the listeners a little bit about that pathway, how you ended up going from social work, or what you went into social work to do, and then how you went into audiology to perhaps fulfill it in a different way?
Absolutely. Yeah. So actually for me, audiology was the one that got away. I was on the fence prior to going the social work route. So as an undergrad, you know how indecisive we can be, right? And
where it's hard to figure out what you want to do.
Exactly. When you don't quite know. So I was attracted to both as helping professions, and sort of at the last minute decided I wanted to go into social work. And I worked for a little while in infant mental health. So there is, infants who are at risk either due to mental health concerns within the family, really young parents, things like that, and
right.
Working in people's homes and working with those infants. One of the things that I kept coming across, of course, was a lot of middle ear disorder in these kids, and a couple here or there that had hearing loss. And so I had that little audiology background calling to me, going, that really was so interesting. So intellectually, I found audiology very interesting. And after I had my son, turned out that it was going to cost money for me to work as a social worker. So I ended up going back to school and completed my AUD. While I was in my AUD program, I was doing a bit of work in a lab. One of my faculty members, Mark DeRuyter, and I was doing a research project and ended up getting hooked on research, and frankly did my PhD simply because I could not do it. Yeah, I could. I just loved the research part. And so I didn't really have any dreams of academia or anything like that. I just really wanted to learn to be a researcher as well. So that's how I came to where I am.
Yeah, I think skills of investigating problems in depth are, not a bad thing, no matter what, even if you're in a position to help with policy like you will be for AAA or any of those things. Understanding in-depth examination of problems, I think, is a very useful skill.
Yeah, be a good consumer of research.
you teach amplification at in your faculty position. So, and you work for Oticon, which is predominantly, it's a hearing aid company.
Mm-hmm.
So they're an amplification company. So tell me a little bit about your interest in that. I mean, it's a huge field, but what are the areas of emphasis or the things that you are interested in, et cetera?
So for teaching, I haven't unfortunately been able to this past year, but had a long history of teaching amplification for Wayne State off and on for many years. And it's an introductory class, so it's always nice to be able to step back and look at the big picture. Fundamentally, though, I view even my role at Oticon as more or less teaching in every respect. So in my role as head of audiology, well, when I first came to Oticon, I worked as a trainer. And so went around and talking about the instruments, software, things like that. And now as head of audiology, I serve as a teacher more at a national level, but also being the voice of the audiologist, being the voice for that patient when I'm in the room with engineers and marketing people and as we're making business decisions and so on. So it's all teaching at one level or another. And so I think that is a role that fits me really well. I never actually wanted to be a teacher, but it's just keep sort of falling into it over and over again.
I think it's the nature of healthcare, actually, right? So it's not just the intervention, it's getting the people, without understanding, compliance is low. And so people need to understand the why behind it. I think kind of the days of, well, you just tell me what I'm going to do and I'm going to do it and I'm not going to ask are long gone. And so part of the process of getting people to engage in their own care is understanding their problem themselves and being able to understand what the goals are. And I think most of the dissatisfaction comes from exactly that, a lack of understanding.
I couldn't agree more. Lots of times people will ask, should I do this way or what are your recommendations? And it's like, well, let's step back and look at the problem. What are we dealing with? What questions are you trying to answer? And really fundamentally understanding the nature of a problem can help, provide that pathway so that you're not just needing an answer, you're learning to find the answer, right? And think through it yourself.
So on the when you wear the Oticon hat, what type of issues are you tackling in the amplification world there?
Today, I am working on ear molds, actually. A lot of continuous improvement in terms of, that's my big project for the day. And the coupling of the instruments to the ears has a profound impact on what the output of the hearing aid is going to be,
That's for sure.
how it looks, how it feels in the ear, and so on. So that's a huge component of what I've been doing as a project is helping with our continuous improvement for that. I work with our colleagues in Denmark. I serve on the Oticon Management Board, which is where we do all of our cognitive psychoacoustic research. Oticon is unique in that it has Oticon really informing not what can we do with the hearing aids, but what should we do with the hearing aids.
Can you expand on that a little? I mean, yep. I'm not disagreeing with you, but that concept is pretty big, actually. So tell me.
Exactly. So, of course, we don't hear with our ears, we hear with our brain. And that's really where we need to start as a field, understanding that, when you hear something, when you understand something, your ears were just the processor that got the sound to the brain. And then the brain has to figure out what to do with it. Your brain doesn't perceive things coming from two different ears. It perceives a single fused image. It is able to localize where sound is coming from. You're able to pick up speech from a crowded room and so on. And all of these are really all about how the brain is working. And so when we design how a hearing aid should work, we're not looking at the audiogram. We're not looking at just, what hearing is lost. We're not just worried about audibility. We're worried about what is the brain going to do with what we're giving it. Sure. And so starting with that in mind then helps to inform, okay, well, what should we do from a signal processing point of view? So we could do any number of things, computer programming. I mean, the technology is limitless.
Fold it and turn it around if you want, right? So it's it's limitless what you can do. But what's the best thing to do, right?
Exactly. So helping, and that's the type of research that's done at Oticon is really helping to inform, what's the next best strategy. until people with hearing loss report no problems whatsoever, we're not done. It's
Sure.
Can we make a simple amplifier? Sure, but that's not good enough. And there's plenty of those out there. But our job as a manufacturer is to, in our view, is to continue to push the boundaries and make refinements about how people are able to perform.
And so from a 40,000 foot view, how do you monitor the brain? How is that done by, what are the tools that people use to do that?
That's a great question. And clinically, we're a little bit challenged because we don't have a lot of the tools in the clinic to do that other than.
I'm in the research. So what are they
Yes.
doing?
Yep, exactly. So because of that, it's helpful that we do have those research components. So there are various ways, including looking at pupil dilation, pupillometry, that is well correlated with listening effort, has been since the 1970s. It's been used as a measure of cognitive effort. So we started using that in our field more recently from a research perspective. And then we can do things like look at EEG, and it has been used as a measure of effort from some other manufacturers. Oticon specifically, or Eric's home, we've been using it to look at actually a following response in the brain, where we can actually see the brain lock onto the envelope of the speech signal. And in doing that, you can actually then measure the salience of that signal in the brain itself at higher cortical levels. And that is really nice because it gives an indication of the ability to actually focus in on that speech signal at a higher level.
So you're kind of measuring the journey of the speech sound up into the brain. Exactly. That's great.
And yeah. And then of course they're looking at other potential measures down the road, and it really all gets to, what is the impact of that hearing loss having on the patient's life. And that is difficult to measure in some ways, quality of life questionnaires, things like that. They seem to be not sensitive in some respects to the challenges that people have with hearing loss. But I can tell you, at the end of the day, they're tired. They're fatigued. They have communication challenges with their family members, and all those things add up to other life challenges as well.
I'm very convinced that even patients, and so even the surveys of people's assessment of their own hearing impairment, and I know the research showed this, but people, I don't know if it got lost in translation, they don't actually correlate very well with the audiogram. And so, even these things that we talk about using within the hearing community are not very powerful. And the reason is people don't know what they don't hear. And so it's very hard to actually ask you, well, you're not hearing things. Can you tell us how that impacts you? It's like, well, I didn't know I wasn't hearing it. Right. And so people's self-assessment and that is why we need objective tools. Right.
Absolutely. Yeah. I mean, when somebody comes in to the clinic, there is absolutely a stigma out there when it comes to hearing aids, when it comes to hearing loss. And so if somebody is in the clinic, it's because they have a problem.
Well, they've already overcome some of the resistance, like making an appointment and driving to the office, right? So
exactly.
But
so
it is amazing.
There,
but there are some people who, even despite all that, they're in total denial, right? Because I always say to them, so did your spouse kidnap you and bring you here and didn't actually tell you why you're coming? I mean, they're kind of playing that cat and mouse game of not really admitting what's going on, right?
Exactly. But yeah, if they're sitting there, something happened that made them feel worse than not wanting hearing aids, right? And whether it's the family member or that person, somebody is suffering, right? And what they want is for that problem to go away, regardless of the fact that it's a hearing loss or any other thing, whatever it is that caused that, they're looking for that to go away. And the hearing loss is one aspect of that. And so, we end up a lot of times acting as marriage counselors, as audiologists or family therapists, really trying to get into some motivational interviewing and it's really behavioral change rather than more than anything else. So.
Yeah. And so, actually, one of the things that came to my mind is what effect do you think patient dissatisfaction has on the stigma of hearing aids? Meaning peer-to-peer negative feedback?
Actually, we don't see that quite that often. I haven't seen it very often. Hearing aid satisfaction is higher than it's ever been. We've got a lot of good data from our market track studies showing that, especially in the U.S., hearing aid satisfaction and hearing care satisfaction is extremely high, much higher than.
I'm sorry though, but isn't that people have actually gotten all the way through, right? So that doesn't measure returns or non-wearers, right? And so that's actually, when I talk to my patients, that's the ones I hear. Well, I had a buddy, he went and tried hearing aids, returned them, didn't go back, right? That's what yeah. So, but I understand people who kind of get to the finish line are very happy.
Yes, absolutely. Yeah. And, for some people in a clinical situation, we would find that, they might get hearing aids, but again, if they weren't quite ready, if they weren't motivated, then there's going to be a return. If they're finding, and so sometimes the dissatisfaction is really a question of what were their expectations and what is their motivation. Right. Plenty of times we would see family members, maybe children bringing their parents in when they went over home to visit them over the holidays. And then, a month later, we'll see that adults, the parents coming back in, returning their hearing.
My daughter said, right. And I got them for my daughter, and now they're back. Now I can
Exactly. So, intrinsically, somebody has to feel that these are going to be beneficial and that that they have a problem that needs to be overcome. If they don't feel they have a problem that needs to be overcome, they don't see the need for solutions.
Right. Yeah. I just wonder, one of the things I always think about is I tell patients your perception doesn't matter. The audiogram shows the deficit. And so it's kind of an interesting, I don't disagree with you, but nobody says, oh my gosh, my blood pressure's high, I need to go get high blood pressure medicine, right? It's an objective measure, but some of it's the mindset. I don't disagree with you. I'm just kind of thinking out loud, if that makes sense.
Yeah. It's a complicated issue, what a person perceives, but it really gets down to what's the impact on your life, and is this going to be a solution for you that's going to benefit you or not? If they don't see a problem or they don't see the solution working for them for whatever reason, they will remain uninterested.
Yeah, no, I hear you. And so I'm sure this is the type of stuff you're exploring in your clinical instruction hat.
Of course, absolutely.
And in your Oticon hat. And then, so the third hat you wear is president-elect. So when does your term start at AAA?
October 1st for the presidency.
So you're going to be busy, but I assume you start doing stuff when you're president-elect and then past president. So you probably have some continuity or something like most. Exactly.
Yep.
And so in that hat, so what are the things that, you see as pressing, or really the things that you're doing? Obviously it's a more macroscopic advocacy policy thing, but what are the biggest issues that are, obviously, not to make this too untimely, but the build back better with hearing aid coverage. I don't know if that's going to be brought back right now, because there's talk of some of that stuff, but I don't know if that's in it. But I think, there was a big talk of hearing aid coverage, and then it kind of just precipitously died out. But anyway, we can talk about the issues that you see in terms of AAA.
Yeah, absolutely. So from policy perspectives and so on, of course, we have a lot of advocacy. We work with other professional organizations to that end. We have a lot of representation in terms of our coding and reimbursement, for example, via the AMA, CPT, and RUC processes. So there's a lot going on.
For the listeners, that's like an alphabet soup of how things get determined, how much they're going to be paid.
What do we bill and how much do we get paid?
Et cetera. It's a complex alphabet soup of processes and bureaucry. So we don't need to.
Exactly.
People want to stay awake, so we won't go through that. But
that's right. Yep. But from an advocacy perspective, any number of things. Infant hearing, ensuring that infants and children have access to hearing screening and early intervention. Those are always top priorities, and funding for that needs to be renewed every few years for early hearing detection and intervention. Student loan forgiveness, and trying to help our students who go through 4 years of graduate education in order to become an audiologist. There are many areas where hearing is a very important healthcare issue that we advocate for hearing care. Now, when it comes to that hearing care and hearing treatment, there are many ways for people to access hearing care. And we are constantly involved in looking at, how can we increase accessibility to that? We have been supportive of over-the-counter hearing aids, for example, and providing feedback to the FDA in terms of their proposed regulations,
Sure.
so that we can ensure patient safety along with that access and efficacy of the devices. We have worked trying to ensure that patients can have direct access to audiologists so that they don't necessarily have to go through a physician
So it
in order
sounds like,
to obtain a hearing test, those types of things.
sure. So it sounds like you've got a lot of your seat at the table when hearing is discussed from a policy point of view, correct?
Yeah.
So
Absolutely, yep.
kind of bigger, like what are the big challenges in audiology, would you say? I mean, I think that's wonderful. I'm glad you guys are doing that work. There's a lot of people doing that work.
Yeah.
Hopefully everybody gets along. Sometimes not everybody gets along, and that's way beyond me. But, in terms of like, what are the bigger things that, we need to tackle as a hearing health community, and your role as AAA bringing that forward? I mean, this stuff is great, but you know what I'm saying? Like, what are the big three? Is it manpower? Is it?
Yeah, I think the biggest challenge is the notion that hearing care is about a gadget, that treatment is about a device, when in fact we know absolutely that patients need care. And so trying to help people understand that, trying to help patients, trying to help other healthcare professionals, trying to help policymakers really understand that patients need care along with those devices. And we know that absolutely, and working for a hearing aid manufacturer, we absolutely know that. We have a global presence, and we know that in countries where people don't have good access to providers, their hearing aid satisfaction is poor, their uptake of devices is poor, even if they can get them very cheaply. So, and there's a lot of good research evidence to support that as well.
No,
I think that's the biggest one.
I agree with you. I mean, it's, one of the things that's always befuddled me is some of the discussions around the policy has been that it's cost. And don't get me wrong, I think cost matters. But on the flip side, there are places where cost is not an issue, and the penetrance of hearing aids is not much higher than the United States. And so doing those types of social comparisons, cost is an issue to everybody for just about almost everything.
Exactly.
But the issue becomes, to me, is cost becomes less of an issue if you see the value in it, and satisfaction is a representation of value. And so I think we're both in agreement that it's the care that matters to get you to that point of getting the value and having your hearing loss treated. Frankly, that's the other thing that I think people underestimate is like you have a non-treated medical problem.
Exactly. And, it is interesting. I mean, you bring up a good point. When I worked at Henry Ford Hospital in Detroit for about 10 years. And in Detroit, there's a lot of UAW union employees.
Yeah, great coverage.
So they had great coverage for hearing aids and hearing care. And, I remember a neighbor of mine had come in, and he said that, his wife told him he has hearing loss. And said, do you think you have hearing loss? Yes, I think I have hearing loss. Do you have trouble? Yes, I have trouble. Do the hearing test. Yes, you do have hearing loss. Your insurance covers hearing aids fully.
I'm not going to wear that.
Help. I'm not going to do that. Well, thanks for coming in. But at least he's informed. Now he knows. And so that's helpful. That's a starting place, and it's a journey for people. It really does take some time. And there's a big difference for people between noticing a hearing loss and being bothered sufficiently by that hearing loss to do something about it. And that's that sort of missing 7 years. And we actually have good data that we collected at Henry Ford on that if you had full coverage for hearing aids, you would get them earlier, but people weren't actually using them, it turned out. And so they'd come back a few years later.
You mean somebody would give them to you earlier, but
Exactly.
You actually didn't get your hearing loss rehabilitated earlier, I think is
Exactly.
Right?
And then, what was interesting though was even, and then for some people where they had a voucher system where they could have a substantial reduction in cost of the hearing aids, if they had to pay anything out of pocket, they waited that extra time. They didn't come and seek care until they were actually bothered by it.
I think actually this all falls on us. I think we're poor at communicating the importance and impact of hearing. I mean, that's what I'm going to tell you. I'm not sure that, I mean, globally healthcare people, not you and me. But my point is I think it's a poorly communicated entity to people. And that's where this all starts. I definitely think we're aligned on that concept, definitely. And so that's the thing that always, I'm not on the policy edge like you are, the seat at the table, but that's one of the things that always kind of befuddle me is people say it's price, but the evidence doesn't support that it actually is price. I mean, again, money does not grow on trees. So, but interestingly, hearing aids could be less than going to Starbucks every day. Right. And
absolutely.
Or smoking cigarettes every day. So there's plenty of things that, relatively speaking. So that's one of the things that's always interesting to me. So it's really a demonstration of value on our part to them.
Oh, absolutely. And I've never met an audiologist who left a patient hanging without a solution. It doesn't matter what their background or socioeconomic resources are. I mean, we find a solution in some way for everybody. And so that's where, again, I think the care piece is really important, knowing that somebody is looking for that best solution for you, regardless of what your resources are.
Well, it sounds like you've got a lot to do in the next year or so. And obviously it's all incremental and, it's probably, the wonderful pay. I'm kidding. You're volunteering your time to advocate for the hearing health community. I really admire that. Thank you for doing that, because it's probably sometimes a pretty thankless job.
It can be. Yeah. And you see a lot of, policy or, just really in the media too, when it comes to, for example, over-the-counter hearing aid legislation, the proposal. Right. We have several audiology groups and all sorts of people who say, you know what, like, let's try to make these regulations be safe, efficacious.
Sensible.
And then there's a lot of pushback in some cases, people accusing industry of like trying to prevent these going forward. And there's no reason for that. Any hearing aid manufacturer could turn around and make an over-the-counter hearing aid tomorrow. There's no barrier of entry there, so it's not about the device, though. It's about the care and missing that care and just knowing, again, it doesn't work well unless there's a professional involved. And that's where we stand on it, but it's hard to be vilified in the media about that.
I agree with you. And the only comment I'm going to say is when you step back a little, there are times where clinical audiologists feel like they're in direct competition with industry due to some of the consolidation and acquisitions that industry have done. And so I think, unfortunately, that stuff bleeds over and people don't have a good ability to compartmentalize it. So I totally understand what you're saying, but having talked to many people about it, I do understand the issue. But you're right. None of that is coming, right? So it's from an advocacy point of view, better to be at the table than not to be at the table, right?
Sure, absolutely.
So, well, this is great. So one of the questions I love to ask people is, what's your favorite sound?
My favorite sound is when my little Yorkie 9-pound dog, she'll start growling at something like she's playing. Just so
your 9-pound dog turns into a 90-pound dog, or at least
exactly. She's just she's playing like she's gonna attack something, but no.
That's really good.
She's like, oh, you're a little wolfie. Oh.
So I don't know how it works, but in our academy, people get to kind of do what they call presidential citations, where they thank people. But I'm not asking you to tell me that. But I always like to ask people, like, who do you thank? Like, who are the people that helped you to get where you are today? And it doesn't have to be professional, but it's kind of that. I mean, it is similar to, I suspect, what you get as your role as president of AAA. But I'm not trying to do an early reveal. I'm just wondering who are the people you thank to help you to get here.
Oh, that's such a great question. I appreciate you asking that. I have had so many amazing mentors and colleagues over the years. And so you almost hate to start making that list, because then it's like, who am I going to leave out? Because everybody has been so great. From my audiology professional career, Brad Stack at Henry Ford Hospital has always been an amazing mentor and colleague and friend. My current boss, Gary Rosenblum at Oticon, who said, when I was nominated and asked to run for AAA, said, yeah, no, this is what's best for the profession, and what's best for the profession is best for us. So go for it. So many friends and colleagues, though, who just support everything. And gosh, it's hard to start naming.
That's fine. That's great.
I just don't want to leave anybody out.
Right,
But
right. Well, then the answer is all those people that are right?
Everybody.
Well, that's great. Well, thank you so much. This has been great. And, I wish you the best on your year of guiding your profession. I think that's wonderful that you're doing that. But this has been a great conversation about a bunch of different topics that are passionate to me and obviously passionate to you. And I really appreciate your time. Thanks for going on. So if people want to get a hold of you, how would they get a hold of you?
They can email me. My email address is vira@oticon.com. So first two letters of my first name, first two letters of my last name, VIRA, or virginia.ramachandran@gmail.com.
Okay, great. So if anybody has any questions or wants to reach out to her, I hope you don't get inundated, but that's how you.
Happy to have it.
Yeah. So I very much appreciate. Thank you so much for coming on today.
Thank you.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.